Okay, welcome. Good afternoon. On behalf of the Center for Environmental Health and Reproductive Health Technologies Project, we welcome you all to the fourth session in the series. In this series, we've been hearing from leading national experts in environmental health and reproductive and developmental health. We have been focusing on a wide range of topics. We started the series with a focus on the broad impacts of fossil fuels on children's development. We also learned about chemical exposure during critical windows of development during puberty and how this can adversely affect reproductive health. In another session, we heard from researchers as they discussed their research on adverse birth outcomes and their research on endocrine disruption and the connection between hormonal disruption and unconventional oil and natural gas production. And last week, we heard about the local community and grassroots perspective and policy efforts, what's been happening in West Virginia and Los Angeles, California, and their history with oil extraction and production. Today, we'll be hearing from some researchers as they discuss the research around unconventional oil, shale gas, and oil development. So with that, I will go ahead and introduce our first speaker. We are honored to have with us today Dr. Bob Harrison. Dr. Harrison is a clinical professor of medicine in the Division of Occupational and Environmental Medicine at the University of California, San Francisco. Dr. Harris founded and has directed UCSF Occupational Health Services for more than 15 years, and now is a senior attending physician. He has diagnosed and treated over 10,000 patients with work and environmental-induced diseases and injuries. He also directs the Working Tracking Investigation Program for the California Department of Public Health. Dr. Harrison received his bachelor's from the University of Rochester and his medical degree from the Albert Einstein College of Medicine. He is board certified in both internal medicine and occupational medicine. He has served on the California Occupational Safety and Health Administration Standards Board and has authored numerous publications in the area of occupational medicine. Dr. Harrison today is going to be talking about his experiences conducting participatory research near oil and gas sites in Pavilion, Wyoming. So Dr. Harrison, thank you so much for joining us today. I will now turn this over to you and make you the presenter in just a moment so you can begin.
I'll go ahead. I assume everybody's able to see my screen. Welcome, everybody. I'm going to relate to you the research and the experience that I've had in assisting a small community in one of our western states and the lessons that we've learned since initiating this project about a year ago. Michael DeBartolomis is an environmental scientist who also works at the California Department of Public Health and is the head of our environmental biomonitoring program. But at the time, Michael was working in his role as an independent consultant. Anything I say today does not reflect, obviously, the views of either the University of California, San Francisco, or the California Department of Public Health.
Dr. Harrison, just letting you know, I think you may have to share your slides. So we're not actually seeing your slides yet.
Oh, okay.
Yep.
You see it now?
There we go. Yep, now we do. Yep.
Okay. All righty. Thank you.
But
sorry about that. Well, you didn't miss anything. You just missed the title slide. And I am trying to advance. There we go. Our research project was a community-based participatory research project in conjunction with a very small rural community located in one of our western states. I am not intentionally sharing much at this point because in about a month we are actually going to be communicating our results to our participants, and as a community-based participatory research program, I want obviously them to have the opportunity to understand and with us plan how the results are more widely publicized. But I can tell you everything about how we set this up and the approach that we took, which I think will be really helpful to you all on the telephone. This project began after one of the organizations assisting this local community took some air samples in proximity to gas wells that were drilled very close to the homes in this small community. And after sharing those results with me, specifically the volatile organic compounds, or VOCs, so if you hear me say VOCs over the next 20 minutes, I'm referring to specific airborne volatile solvents, and in particularly the BTECs, or benzene, toluene, ethylbenzene, and xylene. So if you hear the term BTECs, that's also often a shorthand, but there are numerous other volatile solvents that can be produced from fugitive emissions from existing gas and oil wells. But BTECs is often used as a shorthand, or VOCs. When I looked at those results taken in proximity to these gas wells, I, along with my colleague Michael DeBartolomeus, was sufficiently convinced that there was the potential for community exposure, and I'll show you in a second why when you look at the distance between some of the homes and some of the gas sites. And that led to an exploratory trip, which we took in the spring of 2014. Probably it was just about a year ago, along with the key members of our team. And you can see we're in a little cafe with a pool table. Cheryl Patton from the Commonweal Foundation in a blue shirt, holding the pool cue. In between is Wilma Subra, an extremely knowledgeable environmental scientist and partner who's assisted many local communities around similar issues. Myself in the hat, also holding the pool cue, pretending obviously to play pool in a way that I don't. Michael DeBartolomeus in the hat. Michael I've introduced as a senior scientist with expertise in biomonitoring. Zach Wetstein is standing with a water bottle. Zach was a first year, now a second year medical student at UC San Francisco, who's very interested in a career in environmental medicine. And then Deb Thomas in the sunglasses on the right, on the lower part of the right hand side. Deb was working at the time for the Powder River Basin Resource Council and was working as a community organizer, assisting local communities concerned about health impacts of unconventional oil and gas development. So you can see this slide is what community-based participatory research is all about, is a partnership between impacted communities, environmental researchers and scientists, local nonprofit foundations able to raise some money to support this activity, and a dedicated cast of dedicated but for fairly low-paid volunteers. This was done on a relatively small budget. Quickly in thinking through how we were going to assess the potential health impact or biomonitor this local community and assess VOCs in air. One lesson that I have drawn from this experience is that it would be extremely helpful to have a set of guidelines either published in the peer-reviewed literature or that could be made available to similar local communities around the country to answer seemingly simple questions like, what is the best air sampling method to assess VOCs from unconventional oil and gas wells and measure or assess their impact on local communities? Where is that technology? How is it best deployed? Where are the laboratories that can analyze biological and air sample data? what is the best method to gather those samples in terms of location or frequency of emissions, how do we assess meteorological conditions at the time that we sample, and a whole host of other questions that quickly led me to, you can see on this list, about 25 different people, from community organizations to academic researchers to public health scientists around the country. And as we think through where we might go in the future, I think having a set of standardized guidelines, or at least a review of how this can best be done, so we all don't reinvent the wheel in the future. I think probably many of you know that this has become a subject of great concern because of the vast increase in domestic U.S. oil and gas production. This slide, taken from an oil and gas journal, projects that domestic U.S. oil production will be the highest in 2015, this year, than it has been in the last several decades. Both oil and gas production, this is a map of onshore oil production. You can see where it's concentrated. So it's a regional issue around the United States, but impacts local communities in many states. And I've heard some figures quoted that several million U.S. residents live within a half mile to a mile of an oil and gas well. So there are very many communities around the country that are potentially concerned about this issue. I live in California in the San Francisco Bay Area. If you look at the West Coast map, you can see in California that the oil and gas production is concentrated largely in Southern California, specifically in Bakersfield, in Kern County, where one of the richest oil fields, called the Elk Hills fields, has been under production for at least 100 years. And it was initially operated as a strategic petroleum reserve in California and is now operated by CRC, California Resources Corporation, formerly Occidental Petroleum. We have been very interested in this issue in California because of projections that there are recoverable reserves in the Monterey Shale, which is slightly inland from the Bay Area, extending down through the Central Valley into Kern County. I also have been studying and treating workers with toxic chemical exposures for over 30 years. And my initial attention to this issue was actually spurred by this young man, Dustin Bergsing, who is seen posed with his young fiancée on a Facebook posting, and then written up in a very interesting series, Webb series called Black Gold Boom, How Oil Changed North Dakota. And Dustin was 21 and was working on a remote oil pad in North Dakota and was found, unfortunately, dead at about 1:30 in the morning on a catwalk with an open thief hatch, or an open tank hatch. His job was to gauge the level of production water after this well pad had been drilled and then fracked, and then was producing flowback water about every 2 hours. He would need to go up and basically take a large gauging rod or line to measure the levels in this tank. He was found overcome by a worker about 4 in the morning. Unfortunately, had died and had a postmortem that showed that his blood had absorbed volatile organic compounds that was very similar to the signature of the back-end crude up in North Dakota. He was not wearing any respiratory protection, or had otherwise been really trained to recognize the nature of the toxic chemicals that could be emitted from the top of these tanks. I realized that when I read about his death and did some further investigation, that if these VOCs could be so released in such high concentrations to expose somebody like Dustin, they could also obviously be potentially exposing local communities to these same VOCs. Workers were obviously receiving a much higher exposure, but as we said, as we know in occupational medicine, the canary in the mine. Unfortunately, Dustin was one of those canaries. So with that as background, our journey to this beautiful state was underway. Many communities, individuals are living in the American West for this kind of landscape. It's absolutely gorgeous. Open country, but speckled with oil and gas wells. There are many similar pictures of this in many parts of our country. This is a wooden derrick that is one of the symbols of this state. Their long history of oil and gas exploration dating back for 100, 125 years. So wooden derrick. This would now obviously be replaced by large, much more mechanized, mechanical, enormous metal drilling rigs. These same products that are extracted from the oil and gas wells around the country are shipped in tanker cars, and although we're not going to cover this today as a concern to many local communities as these tankers cars move by, there was just a derailment this past week in, fortunately, a relatively rural area in the Dakotas. I don't believe anybody was injured or killed, but 100 tanker cars roll by through the Bay Area into our refineries, literally about a half a mile from my office right now. Double-walled cars. This has been a subject of a lot of community concern because of the volatility. The context in the western states may be different. Some of it may be the same in terms of the local impact, but the large open expanses, the fiery independence, the transient nature of some of the communities, the large influx of workers who are rotating through, these are all important factors to understand in the context of doing what we would call our community-based participatory research. So as the vistas are filled in with typical production pads that look like this is a finished production pad, you can see that although certainly from an aesthetic point of view, it's not very desirable. From an exposure point of view, there are workers who are servicing these pads, but there aren't any homes around in this view. Or in this view. But then if you look at this view, you begin to see in this small rural community what is a new vista that's developed over the last 10 years with oil and with gas development. You can see there's a little plume off in the distance, some processing stations, and about every quarter mile, probably on average, there's some type of some type of gas pipeline or gas production installation. In this particular part of the country, there's a complex web of mineral and surface rights, and you can see that there's a tribal mineral rights lease to a mid-major oil and gas company on land that's owned by someone who has the surface but not the mineral rights. So this is a complicated issue that differs from different parts of the country. But in this particular state, surface and mineral, as I understand it, are often split. And you can see why a homeowner would be concerned. This is looking at a view through the front yard of a home, looking at a gas pad and a couple of produced water tanks, a truck that's brought in. It's probably a contractor who's servicing the leaseholder who is leasing the pad to a gas production company. These trucks would come through the front yard, the right of access to take the produced water out of those tanks to pump it away and to rumble on out. And here's the swing set and a little red wagon. So this is where children would be obviously playing very close to that gas production pad. I didn't quite understand the process, seeing it firsthand. It's a picture of myself and Zach, one of the community members, showing us what a hatch looked like. Remember, I used the term gauging or a thief hatch. Well, this is a typical example of about a foot wide diameter hatch. This is unvented to the ambient air. Opening up that hatch would have, depending on the amount of produced water or the meteorological conditions and where I would be standing or a worker would be standing, would most likely expose someone to concentrations of VOCs from the several parts to the several thousand parts per million. So with that as background, we gathered in a cafe in a small town, and over coffee and a yellow pad, mapped out the general approach we would take to the research study. The community started by asking us a relatively deceptively simple question, and that is biomonitoring for the chemicals that might be emitted from the gas installations that we see so close to our homes going to show that we're exposed, and if those same chemicals can be found in our blood or urine, be linked to health outcomes. And it's a really quite straightforward question, but is one that's fraught with a whole series of scientific and methodological challenges: who, what, when, where, why. We very quickly decided that doing a health outcome study in this context with relatively small numbers was not going to probably either be that useful or feasible to correlate any health outcomes with exposure, because the numbers in this setting are simply just too small to draw any statistical conclusions. Second, that with few exceptions that I can think of, that biomonitoring in blood or urine is often really challenging to correlate with health outcomes or health impacts. So from the beginning, we were pretty clear with all who were involved that while we thought that biomonitoring was feasible and could be conducted as a pilot, that correlating those with any particular person's health effects was probably not going to be possible for us. That this was a pilot study to develop a method to involve the community, to break some ground for other researchers who might want to follow in other settings or with larger studies. With funding that was provided by Coming Clean to obtain samples, Commonweal Foundation that provided really key administrative support, a small fund from UCSF through a research program for Zach, the medical student, and considerable volunteer and in-kind commitment from myself and many others. We were approved by the UCSF Committee on Human Research. So we did do this as a university IRB approved process. I personally thought that was very important, that we had this secondary layer of review of our questionnaires, of our informed consent, of any ethical issues about disclosure, of where the information were to go, who, where the information resides and how it would be used. All this was very much debated and discussed and reviewed by our UCSF IRB committee. They also had some very good questions and asked us to come back with clarifications a couple of times. That process through IRB probably was about a 2 to 3 month process to go through. So it's not fast, it's more difficult, another layer, but at the end of the day, I think gave us a much better project. So what have we done so far, and how did we design this? We decided to perform biomonitoring blood for VOCs and urine for VOC metabolites. We decided, because of the potential variability over the course of a week, or any time period for that matter, we would focus on our collection over the course of 1 week period. We decided to collect every other day over the course of 1 week, and to collect both blood and urine for metabolites of VOCs. There was nothing special or magic about the 1 week period, or for that matter, every other day. It was really a question of resources and time commitment. Also commitment are the participants to stay with our study over the course of 1 week. We thought potentially it might be more difficult to engage people who have school, work, chores, vacation, etc., to hang in there for more than about a week. We requested, but were not able to have the blood VOCs analyzed by the Centers for Disease Control according to the NHANES method. The National Health and Interview Survey, which is done every 2 years by the Centers for Disease Control, also collects blood and urine for a national population-based biomonitoring sample, which is, I think, probably the best benchmark. We considered recruiting, but did not get a control population, and that was really a matter of logistics and resources. But given that we have a national control population, if you will, or at least a comparison with the NHANES biomonitoring, we first requested that the CDC provide assistance to us for our blood and urine. They declined to provide assistance. We ended up sending our blood for VOCs to NMS, which is a commercial toxicology lab located back east. NMS level of detection for blood VOCs, depending on the VOCs measured, is 1 to 3 orders of magnitude higher than the NHANES biomonitoring. So I would probably not, unless I had a high index of suspicion for occupational exposure levels, recommend the current NMS method for analyzing blood for VOCs, and would instead, as an alternative, look for, if it was available, either the CDC or an academic research lab, so that we would be able to measure to the limits of detection and compare it with the NHANES data. Similarly, urine metabolites for VOCs, there was a published update to the NHANES study over the summer with a couple of dozen urine metabolites for VOCs. We got a few of those analyzed by Dr. Neil Benowitz at UCSF, who does state-of-the-art analyses for primary and secondhand smoke exposures, and has an assay in place for a couple of benzene metabolites, but it's not the full profile. So we were limited also in the urine toxicology that we were able to obtain. We also were interested in knowing something about exposure, and this is a challenging method because of the variability meteorologically in any location, which way the wind blows, the temperature, the time of day. The sampling methodology has also varied from study to study. We decided to use short-term personal exposure monitoring, basically putting SKC active samplers. I don't have a photograph of those. They're about the size of a pack of cigarettes, pardon the allusion there, and it's hooked up to a sampling pump that's drawing air through a sorbent tube that's about the size of a pencil on the lapel in the breathing zone. It's on a shirt pocket. The person can wear it anywhere from an hour to several hours depending on the rate of sampling. And those were sent to Detlef Helmig's lab at UC Boulder Institute of Arctic and Alpine Research. Dr. Helmig is an atmospheric researcher who's been studying and publishing papers on the impact of oil and gas development in the Front Range of Colorado. and what was, I think, very good in terms of the collaboration with Detlev was the ability to compare our samples with the published data elsewhere in the country using the same methodology. Dr. Helmick also took 5 area summa canisters for analysis. These are very short-term, several-minute canister samples, grab samples, that we placed in strategic locations that we thought might reflect instantaneous measures of VOC exposure. And then ALS Life Sciences, which is a commercial lab, has a relatively new personal summa canister that can be worn over 8 hours, and we place those simultaneously with the sorbent tube active samplers for comparison. And then we also send some additional summa canisters to ALS Life Sciences. In a community like this, collecting samples also requires mobility. We did not have access to a university-based or a health department mobile van, but this is my personal mobile recreational vehicle. Zach drove this out, and we used this actually to collect samples from home to home. We'd get informed consent, we'd draw blood, and we'd store it in the refrigerator and then ship them on dry ice. The recruitment was community-based, was door-to-door, word of mouth, with a question and answer session at a local town recreational facility. You can see a picture of me sitting there. Imagine I'm surrounded by the participants in the study, asking a lot of terrific questions about what we were doing, why we were doing it, what answers they would get, and helping us make this study better at the end of the day. So finally, what have we wound up with and where are we now? We ended up with 11 participants over those 5 days. You can see here 27 blood and urine samples, 18 personal summas with 22 personal sorbent tubes, and a total of 8 area summa canisters. We have the results, and we are going to be sharing those in about 6 weeks through letters and a follow-up community meeting, which I think is a very important process with this community-based participatory research method. And finally, remember I showed you the picture of Dustin. There have now been 8 other workplace deaths with the same mechanism that occurred to Dustin Bergseng. And just about a month ago, my colleagues from the National Institute for Occupational Safety and Health updated those worker fatalities in a science blog that they posted. And if you link through this science blog, you will get a summary listing of the circumstances of these fatalities, all occurring in the same way. You can see the plume of hydrocarbon gas and vapor. This is what's seen through a FLIR, an infrared camera that can pick up VOC emissions. They appear in a FLIR as if they're black smoke. And I always think of the old genie out of the bottle picture when I take a look at this. And you can see that if a worker were standing downwind, opening up a flowback tank hatch, that he, and they're almost all men, would be standing in a high concentration of VOCs. So there's a lot of work underway now to reach out to the oil and gas industry. There's some new materials that are going to be coming out from OSHA and NIOSH on protecting workers in oil and gas extraction from gauging and manual tank testing. So final reflections. I think this partnership between university, field scientists, community-based advocates, other partners around the country was incredibly rewarding. We have developed, I think, a lot of good information on best practices and methods as a result of our pilot study. I think it also has shown to us the need to have public health capacity to respond to community health concerns, whether it's the question of biomonitoring or the question of measuring symptoms, to consulting with local healthcare providers when there are concerns about individual diseases or cases. to engaging the local public health infrastructure in a county or a state, this is something that I think is definitely feasible, very valuable. I think there were a lot of mutual respect and gratitude in the study that we did with this local community. It obviously has deep policy implications for climate change. Underlying all this is obviously the question of fossil fuel extraction and ensuring that we minimize the emissions of carbon and atmospheric degrading products. In the Front Range studies, the effects on ozone are quite measurable and of concern in terms of potential health impacts, if not from the VOCs, but from the change in ozone that's measured. So with that, I will wind up, and happy to answer questions after our next speaker.
Great. Thank you so much, Dr. Harrison. Thank you. Thank you so much for sharing your experiences, what you did in Pavilion, Wyoming. I know I am, and I'm sure others are really eager to hear the results of your research when when it's published in the coming months. A clarification came out during your session from Deb Thomas. She just wants others to know that she was not working for Powder River Basin Resource Council during the work with Dr. Harrison. She is and was at the time of the testing working for Shale Test. So I just want attendees to know that they can continue to type in their questions in the GoTo webinar control panel. And at the end of the session, with our next speaker, we'll be sure to have your questions answered. So with that, I'd like to introduce our next speaker. I'm pleased to introduce Dr. Elaine Hill. Dr. Hill is an assistant professor in the Department of Public Health Sciences at the University of Rochester Medical Center. Dr. Hill's research is at the intersection between health policy, the environment, and human capital formation. Her most recent research utilizes quasi-experimental methods to study the impacts of shale gas development on infant health in the United States, which she plans to expand with colleagues at URMC. She is currently involved in early origins research linking in utero environment to later life health and educational attainment. She will also serve to support research projects at the University of Rochester, employing big data structural modeling and cost-effectiveness assessment. Dr. Elaine Hill received her bachelor's in economics and mathematics at Oberlin College in 2005 and her PhD in applied economics from Cornell University in May 2014. Today, Dr. Hill is going to be talking with us about her research on the studies of impacts of shale gas development on infant health. So Elaine, give me one moment here and I will make you the presenter so you can begin.
Thank you. I am coming over a cold, so I apologize if I end up coughing or making a fuss during this, but hopefully I'll be able to manage. I'm really excited to speak with you all today. I'm going to start with a brief overview of some of the environmental pathways of exposure, and then I'm going to sort of give somewhat of a technical discussion around quasi-experimental designs, which are the designs that I use in my own study, and I'm going to use one of my papers as an example and give you some ideas of what those results look like. And then I'm going to talk about some of the research challenges that all studies trying to understand the health implications of shale gas development face, and then I'll finish with some future studies that hopefully somebody out there will end up doing, and maybe I'll participate in some of it. And I look forward to answering questions at the end. So we've already had a wonderful talk by Dr. Harrison, and I think as has been alluded to, the recent expansion of shale gas development, which is often called fracking, has brought these wells into people's backyards. And as of 2011, there were over 1 million active wells in this country in 23 states, and that's quite a bit more to date. And the Wall Street Journal estimates that 15.3 million Americans live within a mile. And if we expand that number out to the other states that have development, some estimate that 1 in 4 Americans live within a mile of an oil or gas well. And so given my interest in reproductive health, with this extreme proximity to residence, it means that pregnant women are being exposed during pregnancy. And so if we use a back of an envelope calculation, I estimate using some rough estimates that we have about 170,000 births that are happening to women who live within a mile of a well every year. So this is a large population of infants that are being exposed during the most important windows of time. And so Ellen mentioned that my research is in the area of early origins, and so I really study this in utero, early environment, and how that may play a role in both what we observe in terms of health at birth, such as birth weight, but also the longer term implications. And I'll talk a little bit more about that later. So the process in question, a lot of people focus on hydraulic fracturing, but that's really a small portion of this larger process of resource extraction. And so as a well is drilled and the well pad is developed and all the materials are coming in, there's truck traffic, there's noise, there's drilling rigs, there's activity on the surface. In this depiction, there's a pit of water, and in some states that's legal and in some it's not. But once the vertical portion of the well is drilled, for those that are shale gas wells, they generally become directional wells and are drilled horizontally underground. And the hydraulic fracturing part is combining water, sand, and chemicals at high pressure to fracture the shale and release the gas, which is then comes to the surface. I'll have some pictures in a moment. But once that flowback period, the part that Dr. Harrison was talking about in terms of the dangers of the volatile organics for workers and potentially families who live nearby, often that comes to the surface at high pressure, and so they need to flare the gas before it can be connected to the pipeline, and then that starts the production phase. And as you'll see in a moment, that entire process has the potential to release volatile organics and other air pollutants into the ambient system. And so that's one of the potential routes of exposure that I focus on in my own research. So here's a few pictures. And in this picture, they're not flaring, although they should. And you can see this sort of plume of methane and other things ending up in the air. But generally, flaring is what they're supposed to do so that then the methane is burned off. But in the process, these non-methane hydrocarbons and other constituents end up becoming ambient. As I mentioned, the truck traffic is certainly a factor. Compressor stations are placed near drilling and continue to work throughout the production period. And so they use diesel engines and release volatile organics and other air pollutants as well. One of the concerns that comes up a lot with respect to the workers is silica exposure. Silicosis or problems with lung cancer can happen from silica exposure, and without this being controlled, it can become ambient and potentially affect the communities as well. And then evaporation ponds. These are a number of pictures from Colorado where water is being sprayed into the air. So with respect to these, the main concerns for human health and for reproductive health in particular are the volatile organic compounds and the butex, benzene, toluene, ethylene, ethylbenzene, and xylene. These ones are the ones that are very concerning for reproductive health and for longer-term cancer incidence. And in addition to that, other core criteria pollutants are also emitted during various phases of the development process. So volatile organics combine with diesel particulates and heat and form ground level ozone, and this is becoming more of a concern, especially in the western part of the U.S. In regions with oil and gas development. So air pollution, although it's becoming more discussed in recent times, when I first started studying this question, was not something that people were even thinking about. Everyone was really concerned about water pollution, but I think air pollution is one of the main exposures that needs to be hammered out in the literature. And this table is just a quick overview of some recent studies that have used quasi-experimental designs to look at different pollutants with respect to infant health. And as you can see, all of the pollutants that are emitted by shale gas development have an implication for birth weight, low birth weight, or premature birth. And so there's certainly this direct connection between these constituents and reproductive health. One of the questions that I think is still outstanding, but this work by Dr. Brown and his co-authors have used some estimates to get us a better sense of how much of these, especially the VOCs, are released into the atmosphere during each leg of the process. And this is definitely an area that we need more information about. Groundwater is a concern for people, especially for people who drink groundwater and they use well water. And recent studies have shown that there are increased levels of various constituents in groundwater and shale plays. One of the open questions that is still being determined in the literature is whether this is naturally occurring because these wells are above shale plays or whether it's related to the development process. But in addition to heavy metals and total dissolved solids, endocrine disrupting chemicals have been associated with drilling density, and there's a number of reasons for potential reasons for groundwater contamination, but most of them are related to accidents or spills, as opposed to with air pollution, where it's a byproduct of the process and potentially more systematic. So wastewater is one of the areas of great concern because of the potential for accidents and spills. And it poses risks for surface water due to waste treatment and the discharge of these constituents after the waste is treated. And so in Pennsylvania in particular, they found that waste effluent has reduce the water quality of lakes and streams, and that the treated produced water often results in toxic disinfectant byproducts. Additionally, in Colorado, they found that endocrine disrupting chemicals have been measured in surface water. And of concern from my perspective, drinking water, about 2/3 of drinking water comes from surface water. And so to date, we have these studies that suggest that there's impact on the quality of surface water, but there's still an open question about how that's impacting public drinking water systems. So something that doesn't come up as much, but I think is of concern for pregnant women is light and noise. If a woman is in her 3rd trimester and already having a difficult time sleeping, and she has this very bright object that's shaking the ground outside of her window, it can be potentially very difficult for her. And I don't know if many of you have seen this picture, but this is from outer space. The Bakken Shale, which Dr. Harrison was talking about, looks like a city, and it's not. That's the flaring from the drilling process. So light pollution is definitely a concern. One of the areas that would be helpful with respect to better understanding the health implications of these different pathways of exposure is looking at biological mechanisms. And Sophia Colburn and her co-authors did the first toxicological assessment of chemicals and the fracturing chemicals used in the process, and found that they affected many different systems in the body. And recent work has shown that one of the concerns is certainly endocrine disruption, which has direct implications for reproductive health. So one of the areas that's pretty lacking, though, is trying to understand these potential multi-chemical exposures, whether they come through ambient air or through drinking, or if somebody's taking a shower and these constituents become ambient in people's homes. And so that's something that is still outstanding. And there's very few studies that have directly addressed these health impacts, and some of it has to do with the quality of data and the availability of data and funding. But Lisa McKenzie, who presented during this webinar recently, they did a study looking at birth defects and exposure to natural gas in Colorado, and found an increased risk of congenital heart defects, which has a relationship to some of these potential exposures. So there's definitely a biological mechanism available there. But in contrast to my study in Colorado, the authors found a slight negative association between residential proximity and preterm birth and low birth weight. And due to the design that I use, I think is the reason, I actually use similar data and find that those who live very close to a well within 1 kilometer face a higher prevalence of preterm birth and low birth weight. But these authors do not use a quasi-experimental design, so I think that that's part of the explanation. So I just wanted to take a moment. I hope this doesn't become too dry for folks, but discussing some of the potential advantages of using quasi-experimental design, which is what I use in my studies. So in order for us to understand whether there is a causal relationship between an exposure and the resulting outcome that we observe, we need a counterfactual. And so often we use in medicine and in other fields randomized control trials because it allows us to randomly assign the treatment to people. But with respect to pollution, and especially with respect to shale gas development, this exposure is not randomly assigned. And part of the reason it's difficult for us to study this is because it would be unethical for us to randomly assign something that is actually dangerous for people's health. And so in the absence of this randomization, we can use quasi-experimental designs, which essentially take natural experiments or artifacts of real life, and we use them to better capture this counterfactual and to do our best to take the variation of exposure that we observe to define a control group that has similar demographic characteristics and experiences, but the main difference is that they have different pollution exposures. And I'll show you how I do that in a moment. But one of the things I wanted to mention was when we use quasi-experimental design, because we're looking at a larger population and we're using statistics and a natural experiment to define the intervention groups, confounding becomes a slightly different issue. And so, for example, if we have a treatment area that's more likely to be sparsely populated, which with respect to shale gas may be true, than control areas, and sparse population is associated with pollution or health, then the population density would be a confounder. But if intervention groups are comparable on population density, so if we compare locations that are similar with respect to population density, then it may not be a confounder. And so what I do in my own study is take similar locations, in fact the same locations over time, and use the timing of when drilling is introduced into the community as the intervention, and I'll show you how that works shortly. There's a number of different methods that can be used that are under this umbrella of quasi-experimental methods, and in this case, treatment and control groups are often defined by time, before and after, which is what I use in my research, or using different areas and using intention or intensity of exposure to define the different groups. And so this is a list of them, and I'm not going to go into detail, but if you had questions, you are welcome to email me. So my recent contributions are in 3 different contexts, and I'm going to share with you the Pennsylvania Marcellus Shale context shortly, but I've also studied this in Colorado and in Texas. And what I do is I use the birth certificate records, which provide a number of different measures of infant health, and the one that I'll focus on today is low birth weight, but I'll show you the results for all of these measures. And as I mentioned, I use a quasi-experimental design, which is called a difference in difference research design. So focusing on the Pennsylvania paper, this is a map of the Pennsylvania well locations from 2008 to 2010, and all of these red triangles are the location of shale gas wells that were drilled during 2008 to 2010. And so as you can see, for the most part, they're densely located in the northeastern part of the state and the southwestern part of the state, although there's some sparse numbers in the middle there. And what I do is I link the maternal address on the birth certificate record to the location of the wells. And so I'm taking all of the births that are recorded in Pennsylvania, and I'm using the maternal address to identify those that are living in close proximity. And then I use the spud date, which is the date that the drill bit hit the ground for the drilling process, to define the timing of when the drilling occurred. Now this has some measurement error because probably there's well pad development and other factors that are happening prior to that moment in time, but due to data limitations, I'm not able to exploit that. And then what I do is I focus on a small radius around the wellhead, which is less than 2.5 kilometers from the well, and I focus on before and after drilling. So it allows me to include locations that are going to have drilling in the future but don't as my control group, and then my treatment group are those locations that have drilling in the current period. And as I mentioned, I use a difference in difference strategy. I control for the covariates that are on the birth certificate record that I think are important for predicting birth or health at birth. So age and race, education, insurance, previous risky pregnancy, current risky pregnancy. I also have maternal smoking behavior, prenatal care, and gender of the infant. And this is somewhat of a technical point, but I use spatial and time fixed effects so that then I'm comparing within the same areas over time as opposed to comparing across areas. So to give you a picture of what this looks like, here we have a gas well, and the distance to the roadway is this 2.5 kilometers. And all of these homes that you see here are my sample in question. And before the well was drilled, this is my control group. And now that the well is being drilled, these are my treatment group. And so all of these homes, if a woman becomes pregnant and gives birth, they're being included in my study. Now, this may take a moment to explain, but on the x-axis, I have distance to the closest well, and on the y-axis, I have the prevalence of low birth weight. The blue line is those control groups. So as you can see, it's a relatively flat line at about 7.5% prevalence of low birth weight across the distances from the well. So they're relatively uniform across that distance. But the red line is the treatment group, and so as you can see, there's a pretty large jump in low birth weight prevalence, and it mimics somewhat of a dose response where there's a higher prevalence of low birth weight closer to the well than further away, and it goes up to about 8.7%. And so that difference is what I'm measuring in my difference in difference design out to 2.5 kilometers. So what I find is that within 2.5 kilometers, there's an increased incidence of low birth weight associated with living near a well that's been drilled, and or that the drilling is happening during pregnancy. And so the prevalence is 25% relative to the mean. There's a reduced term birth weight on average of 50 grams, which is relative to the mean somewhat small, but to compare this to maternal smoking, in this population, that's a reduction of about 130 grams, so it's slightly smaller than half of the effect size for maternal smoking. And then small for gestational age and APGAR scores are also affected in a similar magnitude as low birth weight. What I do not find is any changes in premature birth or gestation length. And what I did was I also geocoded the maternal address to the drinking water source so that then I could compare moms' residences who drink groundwater versus piped public water, because this is, I think, an important question about whether the mechanism might be through water, and I don't find any differences based upon water source. So one of the challenges of quasi-experimental designs is that, like all research, like all models, like all statistics, there are threats to validity that we have to deal with. And so although confounding becomes a different question in these designs, there's still difficulties controlling for confounding. For example, in my own study, the Great Recession coincided perfectly with the start of shale gas development in Pennsylvania. So what I do is, instead of using just before 2008 and after 2008 as my definition of treatment, I use these location-specific time points. So if a community has drilling start in 2010, that's the timing of the exposure, and so then it's slightly more sensitive and more likely to be indicative of an effect related to shale gas development as opposed to secular time trends. Another concern is that with anything with respect to statistics, there's a chance that what we're observing is due to chance. And my own study suffers the most from this problem, which is insufficient data. So having enough time periods and observations. For example, although I can compare different residences, whether they're drinking or presumably drinking piped water versus well water, I don't know whether they're drinking their tap water or whether anyone in their family works in the industry. And then one of the things that, as an economist, concerns me the most is, are companies choosing locations based upon the socioeconomic status of the populations in those communities? And so if the resource extraction is happening systematically in places where political power is less, then that may cause some bias in the estimates. And finally, there's some concerns about challenges of interpretation and alternative explanations. So although I find these pretty consistent effect sizes for low birth weight and other measures of infant health, one of the questions is, what is the mechanism? Is it because of air pollution, water, changes in the community? And so that's one of the challenges that my research design does not allow for a discussion of mechanism as directly as some other methods might. And then with respect to the water source, just because I don't find an effect doesn't mean there isn't an impact. It's just a question of whether it means, is the measures of infant health, are they sensitive to water pollution? Is it that both surface and groundwater are affected? These are some of the questions that remain. So some caveats that are specific to my study. There are many potential confounding factors for observed health, but I use large samples within small geographic areas for this reason, so that then moms are more likely to be homogenous, and I'm able to test this using the covariates that I use in the study and find that these communities are very similar over time. I cannot control for migration of mothers, but I do some work to try to better understand that, and don't find that there's any differences between moms who move or stay when I do observe multiple births to the same mother. I don't observe exposures, as I mentioned, whether mom drinks the tap water, and I don't know whether the family is part of the industry. Now, in terms of being able to better study shale gas development, one of the issues that we face is having accurate and helpful industry data. So right now, it's very difficult for researchers to work with data that give us information over the life course of a well, and provide all sorts of details that would help us to better systematically assess some of these potential factors that we currently are unable to deal with. And one of the things that comes up a lot for me is that we don't have great environmental quality measures before and after, especially at incremental distances from a well, so that then we can better understand what these these implications might be. Now, with respect to communities and health data, it's very difficult outside of birth certificate records and elderly data like Medicare data for us to be able to use administrative data to study health effects in these communities. And so it requires a lot of time and effort to be able to get these health measures, biomarkers, personal exposure measurement, and some of the stuff that Dr. Harrison is doing. And as you can see, one of the limitations of those data is having sufficient sample size. And with respect to reproductive health, knowing fertility decisions and stressors and other factors that may play a role in the woman's health during her pregnancy, I think is one of the areas where, despite my research design, it's difficult to capture. So I just want to put a plug for why reproductive health matters. Adverse birth outcomes are indicative of long-lasting poor health and educational attainment. For example, studies have found that half of low birth weight infants use special education services. They're more likely to use public assistance, or they're less likely to graduate from high school or participate in the labor force. They often experience reduced earnings. And so although low birth weight and premature birth are risk factors for infant mortality, which is heartbreaking, there's also some longer lasting potential implications for these families and communities. A recent study found that a 10% increase in birth weight increases high school graduation, IQ, earnings, and height. And so these outcomes that I've found in these communities are just the beginning, and we need more studies to address the longer-term implications. So I just have a few selected current research gaps, and I don't want to spend too much time on them, but I do want to say that there's a lot of area for more research, and one of the advantages of the quasi-experimental design that I'm utilizing is that it does allow us to use spatial data and temporal data to better isolate what these effects might be when we have administrative data, so that then we can create some hypotheses and better calibrate or design future studies. And so with that, thank you.
Great. Thank you so much, Dr. Hill. That was a really interesting presentation. And I think it's really great, and I really appreciate, sharing the challenges that you faced in studying reproductive health outcomes associated with resource extraction. I think your research is so important, and I really appreciated also that you shared when you talked about light and noise pollution from unconventional oil and natural gas development. I think this is important. It's an important problem that it's not not discussed as far as I know, but I do think it's an important consideration. So we will now go ahead and open up the Q&A session. So please go ahead and feel welcome to continue to enter in your questions into the GoToWebinar control panel, and we'll go through the questions. If we do not get to your question today, we'll be sure to follow up and make sure that to have your questions answered. So the first question here is going to be actually for Dr. Harrison. The question is, should we consider a basic screening tool for people who feel they are getting sick living near oil and gas development sites?
Yes. I'm sorry, I'm laughing. It's a very short answer. I think that would be really helpful. I think having a roster or a registry with a basic tool that can be used. One of the challenges that we had was when we were collecting our data over the course of a week, we did administer a baseline and then a follow-up questionnaire. And although ours was mostly focused on potential exposures that were confounders for VOC exposure, we did ask some health survey questions on those questionnaires, and we begged, borrowed, used from a variety of different survey tools. And I think it would be very helpful, looping back to what I said earlier about having a review and a published set of protocols that can include a basic survey tool, I think would really be very helpful. I really appreciated our last speaker's study design and the methods that she went through. And I think there's a lot to learn. And that would include a standard survey tool that the questioner just mentioned. So long answer, short answer is yes.
Great, thank you. We have another question here for Elaine. The question is, why didn't you use EPA air quality data for your study in Pennsylvania?
So one of the challenges that anybody who's trying to study this will face is that the EPA air quality data in most states in this country are in urban areas. And so as you could see from the map, and if you remember it, most of the locations are in rural areas, and there's really not an air pollution monitor within any distance that that is very meaningful for my own research, and so it would be difficult to assign air quality measures at such a refined geographical scale as what I'm using for my study. And so that is one of the limitations of trying to study this. And there's been a couple of papers that have come out showing how our air pollution monitoring network is not fit to study this question, unfortunately.
Thank you. Dr. Harrison, we have a question for you. The question is, are you going to be releasing your findings to your community participants first? And if so, where can we find these results?
Well, we're going to obviously, and one of the reasons I didn't show you any of the results is because we're going to be releasing it to our community participants first. That's one of the fundamental basis of the CBPR process that I mentioned. But for any good studies that are done, I feel that that's really a key aspect. And so we're going to be discussing with our community partners and releasing the result in some form, and it could be for anywhere from a peer review publication to a summary results that we'll be able to share with the general public health community on a website or through some other media format. We haven't totally decided. I think, personally, I think these results should be shared widely and broadly wherever possible. But stay tuned.
Great, thank you. So I assume that it's okay then that if people have questions or want to follow up with you, they can contact you via email?
Yeah, and I assume people, Ellen, have my email or that you'll make that available. I welcome that.
Okay, what I'll do is I'll share your information at the end of the session.
Okay, thanks.
Dr. Hill, there's a question here for you. The question is, if quasi-experimental designs have so many limitations, why are they considered best practice?
Well, so I think I sort of alluded to this in my talk, but with everything that we do, there's limitations, and so quasi-experimental designs have advantages because they allow us to look at exposures in population and use administrative data that allows us to assess things at an individual level, but also at a community level. And unfortunately, some of the studies that we do at sort of a very micro level, where we have only 50 individuals, it's difficult to then understand how widespread the findings might be, or how externally valid they may be. So quasi-experimental designs are advantageous in a broader toolkit, and in the cases of trying to understand this particular question, I think are useful.
Great, thank you. Dr. Harrison, there's a question here about community-based participatory research in the model. Can you, for people that aren't as familiar with this model and the benefits of using this model, could you talk about it a little bit?
Sure. It is the community-based participatory research, or CBPR, has a lot of research studies and publications. So for anyone who's interested in more information, Google that term or look on medical literature search through the National Library of Medicine. And so it's really very well described and published, but it's essentially, in a nutshell, the engagement with community and with the scientific community, both as partners, to design, implement, and disseminate the results of research findings for intervention, prevention, and action. And the advantages to me, and I've done several worker health studies using this model, but this was one of probably the most intense study that I've done personally, engaged with a community concerned about an environmental health impact. Although I know many of my colleagues probably on the phone have been there and done this many times before me, is that it totally informed the relevance of the results. I think allowed us, so that's number one. I think number two, allowed in this particular setting the trust between the community and myself as a researcher to be able to recruit and get informed consent of participants, to overcome some of the historical distrust of local government, of regulatory agencies, which has evolved over the years in this, and I'm sure elsewhere in the United States. That's number two. Number three would be to really guide how we're going to disseminate and see through what these results mean. The question had come up, well, how am I going to find these results? And I didn't mean to be vague. I think it's a process that is exactly informed by the CBPR model. The results belong both to the researcher, myself and my colleagues, but also belong to the community and the participants who are engaged in this. And that is unlike some of the research that is done traditionally, where subjects or the participants are out there. They enroll in a study and they may read about the results later. They get their individual results, but the impact may not be up to them. And I think that's a third major advantage.
Great, thank you for that. Dr. Hill, a question here is there any research question you think is most important to answer to be able to help us to better understand the impacts of resource extraction on reproductive health?
I think that some of the work that Dr. Harrison is doing is starting to fit into this, but one of the things that has come up with air pollution in particular is these volatile organic compounds and what the exposures may be. And so really researchers studying the emissions of volatile organics at different points during the drilling process at different distances, and sort of mapping out at what points in time there are likely to be the highest exposures, and then what those may look like in community members nearby. And from the biomarker perspective, I think will be really helpful from the perspective of clarifying the biological mechanisms, but also the risks, and potentially helping to better understand policy implications and how we might be able to implement either technology or distances or timings to better inform community members of how to protect themselves. So I really think that that's one of the most important areas that we need to expand into.
Great, thank you. Dr. Hill, there's another question here. The question is, wondering if you could speculate about birth weight. The question is, you seem to show an increase in low birth weight, and the McKenzie study, I guess, may or may not be different. Can you maybe discuss that?
So in McKenzie et al., they actually find that residences that are within 10 miles of a well have higher birth weights, and so there's this inverse relationship between exposure to natural gas wells and birth weight. And I can explain that because I've used similar data. What I find is that those who live closest to the wells are better educated, live in more centrally located communities, and have higher birth weights in what we would call the cross-section. So if you just look at the average at different distance bins, sort of like what I showed in my graph, only instead of stratifying by before and after, I just look at the average, you would see a higher birth weight closer as opposed to further away. But when you stratify by before and after, like I did in my graph, I find the same effect as what I do in Pennsylvania. And so I actually find that living within 1 or 2 kilometers of a well in Colorado increases the prevalence of low birth weight and premature birth. So I think it's just sort of an artifact of needing to utilize the timing in the research design so that then you can better understand the dynamics and what's happening.
Great, thank you for that clarification. There's another question here for you, Dr. Harrison. The question is, to make community monitoring sampling, the community monitoring sampling experience optimal, what would be your recommendations?
I'm not quite sure I understand. So could you say that again? On a community monitoring experience optimal?
So to make the sampling process optimal, what would be your recommendations?
Oh, okay. Well, you know, if we're talking with biomonitoring, because the question, I'm not sure, was directed at either biomonitoring or exposure assessment or air monitoring. If we're talking about biomonitoring, the ideal would be to have blood and urine metabolites for VOCs measured according to the NHANES methodology as published by the National Center for Environmental Health in their annual or every other year updates on the NHANE biomonitoring study. And those methods have been also published in the peer review literature several times. There was a recent paper out of Louisiana from NHANES that was done a couple of years ago, for example. So I would use the NHANES methodology, whether that be at the Atlanta lab at the CDC or with an academic research partner. As far as community air assessment and exposure monitoring, if we're talking at the individual household level, I was fairly impressed with the use of sorbent tube technology that we had. We used an SKC active sampler connected to, as I described, the pencil-like sorbent tube. The sorbent tubes are relatively inexpensive. I think they were on the order of about $20 to $25 each. The SKC active sampler, I think runs about $800 per sampler. I would either look at sorbent tube technology, active sampling. Dr. Helmick also suggested that, and I would probably refer you to him, that passive sorbent tube sampling might be as good as an active sorbent tube, in which case the SKC sampling pumps are not necessary. I know that there are also some other technology development underway for VOC sampling, so I clearly felt that we clearly felt the need for easily available, relatively inexpensive, and accurate to low limits of detection at the household level sampling for VOCs. And I was at the point where we did this about 8 or 9 months ago, looking at sorbent tubes. ALS had the 8-hour SUMAs. I don't know if they still are available and how validated they become at this point. A lot of folks are using the ALS canisters for area samples. And there's these portable little 8-hour SUMAs. I think I would like them to be further validated against some other measures like the sorbent tubes. I hope that it's a long-winded answer. I hope I answered the question.
Thank you for that. There's another question here.
Yeah.
Dr. Harrison, how long did you spend in the field doing the research?
A week. So, we did our data collection over 5 days, but between the enrollment, between recruitment, signed informed consent, preliminary meetings, the actual field data collection was about 7 days. Deb Thomas is on the phone, and she was there, and I think she would agree, although I think she's not able to speak in this format. However, we had a community meeting that were 2 or 3 days prior to the actual data collection, and then there'll be a couple of more days out in the field with the results and a further community meeting to discuss follow-up steps. But the actual data collection was about a week.
Okay, thank you. And then there's the final question here, which I guess could be for either or both of you. And the question is anyone looking at the health implications of potential exposures to more complex organics? And either of you? Yeah.
I don't know of any studies right now.
I think the questioner may be asking beyond reproductive health effects.
It looks that way, yes.
Yeah.
I think it's okay if we want to follow up maybe later.
That's a good question. Yeah. Nothing's flashing, although there's a lot of interest and activity in this area, and so there certainly may be researchers or colleagues, groups in other parts of the country. I don't know offhand.
So for the person that asked that, I will, I think we'll be sure to follow up and try to get you some more information. There's one clarification that came in. Cheryl Patton wants to clarify that there is no Commonweal Foundation. The Commonweal Biomonitoring Resource Center was a member of the community team, and as such was engaged in study design, implementation, and reporting back. And so she just wants to clarify that was the role. Yeah.
Thank you, Cheryl, if you're listening. If I got that wrong, an attribution on the slide. You were obviously an incredible partner and help, as was Deb Thomas, who was listening in.
Great. So thank you both so much. I certainly learned a lot, and I'm sure that others listening in did too. And we really appreciate you taking the time to speak today. So we're going to go ahead and close the session. I want to thank everybody for their questions. If your question was not answered, we'll be sure to follow up and have your question answered at a later point. And I want to also just let people know to be on the lookout for our survey. We really appreciate those of you that have been providing feedback on prior sessions. That really helps us improve the work that we're doing. And then I also want to take a moment to say that we hope that you will be coming back for our final session on Monday. This session will be translating science into policy. So this is this Monday, May 11th from 2 to 3:30 p.m. It's the final session in the series. And joining us for this session, we're going to have some great participants. We'll have Dr. Rachel Morello-Frosch, who's a professor at the Department of Environmental Science, Policy, and Management at the University of California, Berkeley. We'll have Catherine Phillips, the director for Sierra Club, California. And we'll also have Dr. Seth Shankoff, who's the executive director for PSE Healthy Energy. So we hope that you'll be joining us for that final session. And as a reminder also that the recordings for prior sessions are now up on our website, and the recording for this session will be up soon as well. So thanks again, everyone, and we look forward to seeing you on Monday. Have a great rest of your day. Thanks.